This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, an elderly lady presents with an hypermature cataract, and she has this large area of a calcified capsule, and I feel this is going to trouble me when I'm trying to do the rhexis. The surgery is being done under peribulbar anesthesia, and the capsule is stained well with trypan blue, and you can clearly see this zone looks different. Now, she's planned for phacoemulsification. I'm sitting temporarily, so let me start the rhexis. The capsule is punctured with the forceps, the flap is raised, and as I reach the danger area, the tearing of the capsule becomes difficult. It's almost like hitting a roadblock. So my plan is to try to do maybe a smaller rhexis initially and then take a call on how to deal with this. So since that end has hit a roadblock, I'm trying to go in from the other way around, whether maybe this end of the capsule might be slightly healthier. That was my assumption. Slowly but surely I'm trying to tease it out. And again I've hit a roadblock here. The capsule is not tearing. And this is the problem with this. The underlying plaque is extending all the way up to the equator. And my worst fear is if I try to struggle a bit more, there's always a risk of it running to the equator in an uncontrolled fashion. So at this point, I'm thinking what should be my next move. The one option would be always to use a micro scissors and a forceps to cut across the calcific band and then rotate it. The other option which we use often is to peel off the subcapsular plaque. But in this case, the plaque is extending all the way up to the equator and beyond. So peeling it would not be possible. So what is the next option? So the next go-to device for me always is the vitrector. So I prefer to go in and cut this capsule using a vitrector, and I'll just demonstrate how it is done. So this is a Legion machine which I'm using, and it has got an electrical cutter which has a maximum cut rate of 2000, and the irrigation is in my right hand and the cutter is in my left hand. The settings which I'm going to use is the cut rate is obviously going to be the highest which is possible in that machine, that is 2000, and the setting is that it is in IA cut mode. So irrigation, aspiration and then cut mode. So this helps us to grasp the capsule and then make a cut. The bevel is facing anteriorly and then I begin the cutting. One important principle to follow is when you're doing this vitrector assisted capsulotomy, we should not move the hand in a jerky way. Just hold the hand still at a particular point for a few seconds, then gently move to the next second and then start continue cutting. So if you make jerky movements, there is always a risk of the tear going in an uncontrolled fashion. Slowly but surely the cutter is just nibbling around, and this cutter is nibbling at the anticapsule. Because I'm doing it under direct visualization, I really know what it is cutting. One needs to be a little bit careful when we are much more near the pupillary margin. But what I like about this technique is it's extremely controlled, it is predictable. You're going to cut the capsule without inducing any stress on the zonules. So if we zoom in, we can see there is multiple scalloped edges or the capsulotomy edge, but they are quite strong. They're unlikely to extend to the equator during nucleus management stage. So I want to enlarge the capsulotomy to a decent size simply because the underlying nucleus is also quite dense. So I don't want to struggle or put any stress on the capsulotomy margins during the nucleus division technique. So I'm a little bit aggressive as far as sizing of the rhexis is concerned. Now coming to the left side of the capsulotomy opening, which is healthy capsule. In this area, I would like to use the scissors to make a tangential nick and then use the forceps to convert it into a bigger rhexis. So now the situation is good. The most difficult aspect of the surgery has been taken care of. Now is the time to deal with the nucleus. So as is typical in these dense nucleus, I'd like to create a small central pit by trenching or sculpting. And once I'm 50% depth, I switch on to the chop mode and use the longitudinal energy to bury my tip into the substance of the nucleus. The chopper goes down vertically and there is a lateral separation maneuver. The nucleus is subsequently divided into multiple small fragments. Now, as the lateral separation maneuvers are being done, you can see that there is no distortion of the capsulotomy margins, they stay put. And this just reaffirms the strength of the edges which are cut by the vitrector. So of course it cannot be compared to the strength of a manual rhexis, but it has got the ability to withstand the pressure which is exerted during a routine emulsification of a nucleus. So that should be good enough for us, because in such complex cases, having some sort of an capsulotomy which is strong is a reasonably good idea. So the nucleus is done, but hang on, there is more drama to follow. The moment the last piece is out, what I am seeing is a very dirty looking posterior capsule with lots of capsular plaques and fibrosis in and around the visual axis, and also we can see multiple tiny dots in the space posterior to the posterior capsule. Well, this indicates that there has been some sort of a fluid misdirection happening because of the probable loss of the zonular barrier, which is to be expected in these long-standing cataracts. Now, regarding this posterior capsule, I don't want to leave it like this. I want to clean it. And unfortunately, I'm unable to polish it, or it's unlikely to go. The best way to deal with this is to do a posterior capsulorhexis. Should I do a manual capsulorhexis, or should I just postpone and do a YAG laser later? Well, it's perfectly fine to do a YAG laser later. There's no question about that. But in this case, I would want to just deal with this issue right now. Should I perform a manual PCC or vitrector assisted PCC? So I did not go for the manual posterior capsulorhexis simply because doing it is much more difficult in this eye, because I don't expect a strong zonular support, which is critical when you have to do a rhexis, especially the posterior capsulorhexis. So it can become a little bit tricky for me to tear the posterior capsule, and that's the reason why I have opted out for the vitrector assisted posterior capsulotomy. But I would like to do it after the lens implantation. So the planned lens is placed into the bag under the cover of OVD. Now once the lens is in place, I go in with my cutter with its bevel facing down. Again, the setting is IA cut mode. The capsule is engaged, and just a few cuts we're able to open the posterior capsule. Now the setting is again changed to the vitrectomy mode, that is irrigation cut aspiration mode, and I do a limited anti-vitrectomy. I'm aiming to perform a small, maybe 3 mm central opening in the posterior capsule with the cutter itself. The lens is centered back. OVD in front of the lens is aspirated out. I'm injecting a little bit of a diluted triamcinolone acetate just to check for any evidence of vitreous prolapse in the antechamber. Thankfully, there is none. The lens looks to be well centered. The visual axis is clear. Side ports are hydrated. That's it. The case is done. These are the first day post-op pictures, and these are the pictures on the subsequent visit. That is the third visit. The cornea is clear. The patient is happy. The visual axis is clear, and on dilatation, the lens appears to be well centered. To summarize, in some of these tough cases like this fibrotic capsule, vitrector is a great boon for cataract surgeons to fashion a capsulotomy which provides a reasonable strength, good enough for us to perform phacoemulsification. And in this case, I also use the vitrector to perform the posterior capsulotomy, and it did serve me well. That was it. Thank you for watching, and hope you found this helpful.